So with no further ado, I'd like to introduce our first speaker today, Dr. Ruth Cunningham. Ruth is from Dunedin and is a public health physician in the Department of Public Health at the University of Otago. She's currently completed a PhD, or is completing a PhD.
Still doing
it. Right, you're still doing it, right. Which is focusing on the impact of recent mental illness on cancer survival. She's recently published on premature mortality in adults using mental health services in New Zealand. So, welcome, Ruth.
Kia ora tātou, my name's Ruth Cunningham and I work here at the University of Otago, Wellington. I'm a public health physician by background, and so that's the lens that I bring to this work, and I've previously worked quite a lot in health inequalities research, so I think I bring some slightly different thinking, or some broader thinking about health inequalities that I want to share. So I'm going to talk to you today about some work I've been doing using routine data, but I just want to acknowledge Kato, and I want to acknowledge actually that there's real people behind the routine data, behind the numbers. These are about real people with lived experience. Oh, no, that way, sorry. Okay, so I'm going to talk a little bit about my background and about health inequalities research, about some different things we can do with routine data, about some work on premature mortality that Janice mentioned, and also a little bit of work around cancer, and about what this can aid, how this can aid our thinking about what some of the causes are for poor health outcomes and what we can do about it, which I think is what we're here for today. So this is a little quote about, I guess, what I mean by health inequalities. So I'll just read it to you because I think it's quite a good one. Inequalities arise from and are maintained by the unequal distribution of the determinants of health, such as income, employment, education, housing, healthcare, and social support. It is the privileging of some people and groups over others by factors such as ethnicity, class, gender, geography, or ableism that generate social inequalities. Inequalities are therefore the unfair and unjust result of social and economic policies and practices. And just as inequalities have developed, they can be reduced. And actually, I think that this definition of what health inequalities are about resonates with this issue that we're talking about today. And how does a sort of health inequalities approach lead us to thinking about what some of the solutions might be? So this is from, it's quite old now, but something from the Ministry of Health around reducing inequalities in health, and thinking about actually how we have to think about intervening at lots of different levels, how we have to think about intervening at the structural level and thinking about discrimination in our society, how we also have to think about the intermediary factors, which are things like access to employment and housing, but also factors such as diet and smoking. How we also have to think about the role of health services, and how we have to think about the way that there's a sort of feedback loop where, and it's particularly relevant to us here talking about mental health problems, how if that leads to physical health problems and discrimination, it can also lead to socioeconomic deprivation, and it can just go round and round. So thinking about that kind of feedback as well. But thinking about how we have to think about intervening on lots of different levels. And just a little example from work of colleagues of mine in public health, thinking about what some of the drivers of ethnic inequalities in health are, and how these are all examples of how we can use routine data. So how we've seen that unequal access to health services and unequal pathways through health services have been a driver for ethnic inequalities, particularly Māori, non-Māori this work is about, but also how actually racism itself impacts on health status. And I think that that's an important to take some lessons from this work when we're thinking about the impact of discrimination on health. So what have I been doing? So I've been linking routine data sets. So my work focuses on people who have experienced mental illness disruptive enough to lead to contact with secondary services. That's not everybody with experience in mental illness, but that is the group that I have been focusing on. So I've been using information from mental health service data, from all the different places that we collect routine data in health services, and linking them together. So I'm going to talk about two examples. Firstly, premature mortality, and this was recently published in the New Zealand Medical Journal. So by premature mortality, I mean the risk of dying before the age of 65. So, and this work compares people who have previously used mental health services with the general population in New Zealand. And what's the answer? Do people using mental health services die early? Yes, they do. So this shows, so one would be no difference between people using mental health services and the rest of the population. And you can see on the left, this is everyone in contact with mental health services, and there's twice the risk of dying before the age of 65. So that's a huge difference. And then for people with schizophrenia and bipolar disorder, actually, it's 3 times the risk of dying, men and women. So this is a huge difference. This is a huge inequality. And what's it caused by? Is it dying prematurely of suicide, or is it actually a whole lot of other things? And actually, most of these premature deaths are from natural causes. Most of the deaths are due to dying prematurely from cardiovascular disease, from cancer, from the same thing that everyone in the population dies for. So I think that this focus on physical health is a really important one. Why? This is me starting to try and map out some of the things that I think are important, both at the level of society, at the level of health services, at the level of medications and diet and smoking and things like that. There's a whole lot of things going on, and it is about quality, and when we think about health services, we have to think about access to quality care for everyone, including those with experience of mental illness. So I think that this data is important for starting to raise the issues. We're all aware of them here today, but I think it's really powerful to be able to say, actually, look, this is double the risk of dying prematurely. This is a really big difference. They're important that we continue to monitor these things, but I think if we want to drill down and understand the causes, we need to also focus on some of the individual diseases that are a problem here. So my PhD work is around cancer survival. I've been looking at people who've been diagnosed with breast and colorectal cancer in New Zealand as 2 of the sort of most common cancers, and looking at the risk of dying from those cancers in 5 years, so 5 years after diagnosis, comparing people who had contact with secondary mental health services in the 5 years prior to their cancer diagnosis with people who had not had contact with mental health services. So the blue line is everyone who didn't have contact with mental health services. This is breast cancer. The blue line, and you can see that, so that's the chance of dying or the chance of surviving. So that you can see that the blue line shows about 90% of people, women with breast cancer, under 65, were still alive after 5 years. The green line represents most people using mental health services, and you can see that there is a higher risk of dying or a worse chance of survival for that group. And the red line is those people who had diagnoses of functional psychosis, of schizophrenia and bipolar disorder, and it's even worse. Okay, so this is just, it's another demonstration of what we just saw with the mortality stuff, but showing that actually, even with cancer, and when I started to do this work, my colleagues who work in health inequalities research said, you'll never find a difference with cancer. Cancer treatment is so good, there's never going to be a difference. Actually, this is a bigger difference than we've seen with ethnic inequalities in cancer survival. So this is real. Colorectal cancer, so you can see the first thing is that colorectal cancer is more likely to kill you. But the second thing is that red line is pretty startling. I haven't put the confidence intervals on here, but they are significant. But yeah, the chances of dying from colorectal cancer for people who, so this is people who have diagnoses of schizophrenia or bipolar disorder and are diagnosed with colorectal cancer. Okay, so that's the sort of crude thing. Again, this is a similar kind of diagram trying to get us thinking about all the ways in which the reasons this might be happening. I do have a pointer. Some of the things that we can sort of measure in the routine data around comorbidity. So that's actually, for this, it's did you have metabolic syndrome when you were diagnosed with cancer? Did you have other physical health problems when you came to be diagnosed with cancer? And so we can actually look at the role of that in this worst cancer survival. We can also look at, are cancers being diagnosed later? and quality of treatment is important. So I'm just going to walk you through this horrible table. So this is just basically the same thing as we just saw on the graphs. This is breast cancer. So for women with those psychosis diagnoses, it's 155% increased risk of dying within 5 years. So a huge difference. It didn't actually look that huge on the first graph we saw. And so this is that. So this second line is taking into account differences in age and ethnicity of the different populations. So we know that Māori are overrepresented in the mental health services population. But also for the rest of, for other women using mental health services, there's also a 60% increased risk of dying from your breast cancer, which is pretty big. Sorry, I'm getting there, James. Is it about being diagnosed late? So for this group, for the group A, for women with schizophrenia and bipolar disorder, yes, it probably is about being diagnosed late. That does seem to that does seem to explain some of the difference. But for the other woman, actually, no, it doesn't really explain any of the difference. It's not about being diagnosed late. So we also have to think about. It's too much whispering. So being diagnosed late is important, but it's not the whole story at all. Is it about living in deprived circumstances? We know that, particularly for people with psychotic disorders, that can lead to a downward spiral of employment, not being able to stay in employment. It can lead to not having great housing. It can lead to all sorts of other problems. Does that explain this difference? No, it doesn't. And is it about what I mentioned before about comorbid illness? Is it about actually coming into a cancer diagnosis with a whole lot of other things going on, which we know is the case? And yes, that is important. So it seemed to explain about 20% of the difference for both groups. So what does all that mean? And So we could explain all those things. What I couldn't account for, and what I showed at the beginning around Māori health, was actually treatment differences matter too. We've found that in thinking about other health inequalities. There are still big differences, even when we account for stage at diagnosis, even when we account for coming in with more physical health problems. There's likely to be differences in treatment. It was not possible to examine them properly from the routine data, but I think that that's an important next step, because I think it's really powerful when you can show clinicians, for example in this case cancer clinicians, that actually it is making a difference to the treatment that people are getting, the fact that they have a diagnosis of a mental health problem. We've found that in thinking about ethnic inequalities in health, and I think that we also need to have this information to put in front of people in this area as well. We did it for colorectal cancer. We found basically the same thing. So it's not just about breast cancer. It's not just about women. It's men as well in this one. So we found the same sort of thing. So what does it mean for... So this is focusing on cancer. What does it mean for improving cancer outcomes? It means that screening and early diagnosis are important, but they're not by any means the whole story. It means that managing other medical conditions, thinking about the drugs that are being prescribed, thinking about smoking are important, but actually it's also about ensuring that there's quality treatment provided right through the health system. So I think that using this routine data is really helpful for highlighting the inequalities that exist, and it's helpful for starting to explore some of these inequalities, starting to try and understand what some of the pathways might be, and then actually finding the evidence for whether these pathways are important. We need to do more research around treatment receipt, because I think that is an important area. And we also need to drill down into some of the other health conditions. This is cancer. I think that lots of the lessons will be similar, and actually, as my colleague said when I was starting, you'll never find it in cancer because cancer treatment is so good. Actually, if we're finding it in cancer, we're going to be finding bigger things elsewhere. So I think looking more broadly is important. So I want to acknowledge, so I'm doing a PhD, this is a part of my PhD work. I'm a public health physician by background, so I come in with a sort of a clinical background. I want to acknowledge my supervisors. I want to acknowledge the importance of having people with lived experience inputting into the work I'm doing, including on my supervision team. And yeah, I hope, I'm excited to see what we can come up with for this day.
Can I just give you an anecdotal situation that happened to a close friend of mine who's got a psychotic diagnosis and has been medicated for 30 years. She developed breast cancer and she had to travel from Whangarei down to Auckland to get treatment.
Yeah.
When she turned up at the residential place, she was told she was not allowed to stay there and she was sent to a geriatric hospital where she had to reside for the duration of her treatment, which I think was about 5 days. So she had to be taxied from that place to the oncology ward to get her treatment. So she was physically turned away at the door. So I just thought that it's important that these are the experiences that people are having, which probably doesn't help outcomes either.
No, absolutely. And I think, I mean, I guess I come to this work having worked both as a junior psychiatric doctor and as a junior doctor in, on medical wards, and having seen, having experienced a medical registrar who wouldn't come across to see someone on the psychiatric ward, having experienced being in a position as the most junior doctor trying to manage some really serious and long-term physical health problems in a team. So yes, absolutely, this is very real, and yeah.
Thank you, Ruth. We've got a little bit of time for some more questions. Any more questions? We might have to shout.
Well, thanks, Ruth. I just going to raise one issue about sometimes when you get a sort of being an epidemiologist as well.
Yeah.
That sometimes when you get strong association, you adjust for various things which you haven't got a lot of information around. It's and the measure of association comes down.
Yeah.
It can be that there is some residual confounding that you haven't. So I just thought I'd highlight that as another possible explanation for some of your findings.
So, thank you, Simon. Yes, I agree that particularly around measuring comorbidity or measuring the burden of disease, burden of other physical health problems that someone comes into cancer treatment with, it's true that it's measured as best we can, but it's using the routinely collected information. I tried a couple of measures. This one explained more, the one I used, than another one. But yes, it is possible that is explaining more of the problem. Yeah.
Oh, kia ora tātou. Did you split out that data by ethnicity?
So the mortality stuff, yes, I have looked at it by ethnicity. So that's everyone grouped together that I've shown. We also looked specifically at Māori using mental health services compared to Māori not using mental health, or compared to the general Māori population, and we found a higher risk of premature mortality. The difference was a little less because of the higher baseline risk of premature mortality for Māori. So yes, it is important to explore the differences by ethnicity, and yes, this is an issue for Māori as well, unsurprisingly. For the cancer survival stuff, because of the small numbers, I haven't been able to look at Māori separately, but it is some work I want to look further into, yeah.
Can I speak? Yeah. Thanks, Ruth. The odds ratios of 2 to 3, or relative risk of 2 to 3, as you say, important. But what it tells you straight away is there's a lot of people who are in the risk category that don't progress, in this case to premature mortality. And so I'd encourage you to, with your data, to have a look at those people that don't follow that trajectory as a way of trying to squeeze more out of the data in terms of what protects, because that starts to shed a lens on possible mechanisms. So nice data set, nice work, and I think you could do even more with it.
Yep. No, thank you.
Thank you. Just a question for me. In any of the data that you investigated, do you think there's any geographical variation?
I've started to look at it, and there doesn't seem to. Well, yeah, we would expect some. Partly, we would expect some just because we'll have slightly different groups of people using mental health services in different regions. So just the the way that different services are operating is likely to result in some differences. And there will also be geographic differences, and we know that there are geographic differences in access to cancer treatment. So I've started to look at it again. I run into problems with small numbers, but it's an interesting issue. Yeah.
Okay, well, please join with me again in thanking you.